نرحب بحضرتك، انت اخ فاضل وصديق عزيز.
الله يخليك يا بيه.
ويعني شرف
حضرتك
ان
أخ
انا
أكبر
اقدم حضرتك.
وغالي.
واتفضل دكتور حسام.
شكرا. انا بشكر دكتور محمد عامر دعوتي يير ان ريفيو سكسس افتر انذر، وان شاء الله مستمر. بشكر شركه فاركو لاختياري معاهم في السيمبوزيوم. and it's a case presentation about gastroesophageal reflux disease. GERD سمعنا كتير GERD وسمعنا جايد لاينز وسمعنا case presentations، فانا حطيت touch of emotions and romance كانت موجوده الحقيقه في الكيس نفسها. This is the case of, can I have the slides please? Can I have the slides? Okay. That is a real patient of mine, chronic GERD patient, came to see me for a routine checkup as usual, accompanied by his shining wife and soulmate as he calls her, and I call them both Mr. Romeo and Mrs. Juliet. هو راجل عنده 70 سنة, obese patient with long-standing history of GERD grade C. He is otherwise well except for controlled hypertension. He is a smoker with no history of weight loss or other red flags. He had no complaints وجاي break the good news انه thank you very much. انا يظهر ان انا خفيت والاعراض كلها راحت حتى وانا موقف الدواء. So what would you do for this patient? Continue his on-demand maintenance therapy ولا stop maintenance therapy till he develops symptoms نبقى نديله تاني, ولا proceed to endoscopy in spite his no complaint? Endoscopy? Continue. الحقيقه انا قلقت من الشكوى بتاعت stopping الميديكال تريتمنت ويبقى ما عندوش symptoms, because this could mean that he developed Barrett او even adenocarcinoma on top of Barrett. ودول ال 5 cases when we do endoscopy في عيان reflux disease. Failure of a PPI therapeutic trial, patients with alarming features at presentation, patients previously endoscoped وعارفين ان هم C زي البيشنت بتاعنا ده, و patients older than 50 years و chronic patients who reported sudden unusual disappearance of his heartburn on no treatment برضه زي البيشنت بتاعنا ده. So we proceeded to endoscopy. بدأت أحس إن his wife was not feeling well ومش shining as usual and she was continuously coughing, which caught my attention لأن خفت يبقى عندها حاجة infectious COVID أو حاجة when this was in the era of COVID. فسألتها but she said no, I'm fine, it's not COVID, it's not an acute infection, I'm allergic وبكح بقالي حوالي 4 شهور. شافت pulmonologist, شافت ENT specialist with in vain يعني her cough was getting even worse. So I offered actually a complimentary visit, suspecting انها تكون GERD. I did not ignore. هي 62-year-old lady, not diabetic, not hypertensive. She has no heartburn or upper GI symptoms at all. هي بس عندها الكرونيك كوف ده, و she reported gain of weight in about 9 kilograms in the past few months. And she is on bisphosphonates. So what's next? Would you recommend upper GI endoscopy for her? Query GERD. Give empirical PPI treatment and follow up. Well, this is not GERD. Forget about her. She has no GI symptoms. She has no typical reflux symptoms. بس ده ما يمنعش انها تكون برضه reflux disease, لانه الاكسترا manifestations of reflux او atypical symptoms of reflux اللي منهم الكرونيك كوف ممكن يجي on top of heartburn او without heartburn and without any GI symptoms, كل واحد من دول هيتعامل بطريقه الحقيقه. We know الكوف سواء vagal reflex او direct contact هو السبب في الهارتبيرن, سوري الاسيد اللي بيطلع هو السبب. In this case الdiagnostic algorithm بتاعنا we did not start with a PPI therapeutic test لان البيشنت she has no history or no complaint or symptoms of heartburn. Extraesophageal manifestations, الجايد لاينز بتقول ايه؟ بتقول اللي احنا قلناه ده, انه لو معهوش heartburn او esophageal symptoms we proceed to endoscopy او pH monitoring. If not يعني heartburn ومعاها extraesophageal we can apply a therapeutic trial. So I recommended we proceed directly to upper GI, but she refused. She was asking about لو في أي new developments. الحقيقة ما عنديش new developments concrete أو approved أقدر أقولها، لكن in the pipeline ممكن نشوف salivary pepsin testing يطلع، وممكن نشوف ambulatory cough sound recording device، لكن ده حاليا مش موجود. Mrs. Juliet, as I call her, after failing to convince her, I prescribed pantoprazole 30 milligrams once daily for 6 weeks, and follow-up بتاع Mr. Romeo was before her, so in 2 weeks he came for his endoscopy. At this visit, Mrs. Juliet كان شكلها بتتحسن. This is the endoscopy of Mr. Romeo. Okay, this is a Barrett, a query Barrett patch in the lower esophagus. It was biopsied. Mr. Romeo and Mrs. Juliet Romeo were both very worried concerned about Barrett. بقى مش فاهم, is this something serious? أنا عندي مشكلة كبيرة. So I had to explain for reassurance, and I explained everything about Barrett. وأهم الحقيقة thing to explain is the surveillance, because surveillance مفيش حاجة متفقة عليه الحقيقة. I also told him that we need surveillance عشان the cancer risk, and I explained the cancer risk. Histopathology confirmed the diagnosis of Barrett esophagus with no dysplasia. How to manage? We continued with on-demand therapy and endoscopy if develop alarming symptom. Lifestyle modification is only complementary, with symptom analysis follow-up is important. Follow-up يعني قدر الامكان يتعمل بهاي ديفينيشن اندوسكوبي، اتليست هاي ديفينيشن، مش لازم كل الاندوسكوبيك ايمج انهانس اندوسكوبي، بس اتليست هاي ديفينيشن اندوسكوب. The standard dose of PPI versus PCAP continuously was studied. Continuous acid suppression with a PPI at a standard dose was clearly more than enough. I could not ignore ان في حاجه كبيره جايه اسمها PCAP, so we had to talk about it. مش بس علشان في limitations، مش بس مقارنة head to head. الحقيقة أنا I want to draw the attention to optimizing treatment. مش معنى أن عندنا in our armamentarium سلاح جديد إن it is superior أو it is better used. We have to optimize our resources, and we have to know out of experience when to use what. Clearly لما يكون عندي PPI stood the test of time, using PPI more than 30 years now with no complications, clearly it's my first choice. إلا في حاجات made it to the guidelines زي مثلا ال H. pylori, which is now probably الدفة رايحة ناحية ال PCABs أكتر. طب which PPI؟ عندنا some studies comparing ال pantoprazole أو studying ال pantoprazole تحديدا في ال nocturnal acid breakthrough, and head-to-head studies مع ال esomeprazole showing slight superiority. Lifestyle modifications in as regards the cancer risk, الحاجة الوحيدة اللي بتفرق as per guidelines is obesity and smoking. طيب lifestyle modification عشان control the symptom أو symptom relief, weight loss, elevation of the head end of the bend. دي الحاجة الوحيدة اللي scientifically proven علشان to relieve the symptoms, and this is what the guidelines says. Symptom analysis في البارت is important لأنه the symptoms are directly related to the increased risk of adenocarcinoma, and esophageal adenocarcinoma risk is increased مع GERD symptoms frequency, والseverity كمان is also important. Endoscopy زي ما احنا شايفين we reached a level of high-end endoscopy. We are seeing pathology in vivo pathology, so we have to be ready to incorporate pathology in the curriculum of GI teaching, or at least have a pathologist with you on board in more like an MDT approach. We're short of time, so I will not show much of the videos. Back to the patient, I prescribed him pantoprazole 40 milligram once daily, continuous dose, not on-demand therapy. I also advised some lifestyle modification, most importantly, weight loss. He asked about the possibility of undergoing a bariatric surgery علشان you lose weight, which is a good idea actually, but you have to choose right. Sleeve gastrectomy is a refluxating surgery. We never do sleeve in a patient with reflux disease. Better is the Roux-en-Y bypass, and some of the endoscopic maneuvers as well could help, especially endoscopic maneuvering, mimicking the TIF process, and this is also proven by guidelines, or backed up by guidelines. So about the soulmate. Now Mr. Romeo is settled. Mrs. Juliet came to surrender to endoscopy بعد ما شافت ان endoscopy فرق كتير في management of her husband, and we performed endoscopy next day. كان عندها hiatal hernia بس ما كانش عندها signs of reflux disease. عندها mild gastritis والbiopsy طلعت انها H. pylori positive. This is what we normally see in endoscopy. At this point, do you consider an established diagnosis of NERD and put the patient on a maintenance therapy scheme, while perform ambulatory pH monitoring? I will not waste time waiting for results, answers, because the answer is clear. We moved straight away to ambulatory pH monitoring, which can be done أحسن دلوقتي. يعني برافو كبسول بتدي وقت أكتر شوية للpatient, but it's not very accurate. Impedance is very important, لأن impedance هيفرق لي acid and non-acid reflux, or even if it was air reflux, not even fluid. High resolution manometry is essential before surgery. So treatment for Mrs. Juliet, we chose the regimen, the guidelines recommended اللي هو step down approach, ان انا ابتدي high dose PPI وبعد كده taper down to the lowest effective dose. والstudies أكدت ان step down therapy is superior. Mrs. Gillette has had many questions الحقيقة. يعني she needed to take medications daily ولا on demand, side effects. Will she start story? So the answers were no. هي هتكمل treatment for a very long time. GERD or NERD in her case is a chronic disease. Lowest effective dose is to be used. No concrete evidence of any effectiveness of prokinetics. Prokinetics is out of the guidelines. الترانزيانت لور sphincter هو اللي مسؤول هي عن الجيرد symptoms من كتر الريلاكسيشنز اللي بتحصل. عندنا دواء اسمه باكلوفين بيقلل شويه الترانزيانت لور sphincters and it helps in refractory GERD. بس الدوزز needed are not safe in GERD. هو دواء موجود مصر ريلاكسن 10 ملغ لكن بنحتاج up to 40 ملغ علشان الجيرد symptoms يعني. I have to run H. pylori treat or not to treat, لأن كان في concept إن ال H. pylori بيعمل alkaline medium which is good for the patient with reflux disease. بدل ما يبقى عنده acidic medium يبقى عنده alkaline medium. This is no more valid. H. pylori, a good H. pylori is a dead H. pylori. Whenever you see H. pylori, please kill it. Medications may aggravate GERD symptoms. Very important to note. We are dealing with a patient مش جهاز هضمي ماشي على رجلين، فممكن يكون بياخد أدوية تانية، والأدوية التانية دي هي اللي ممكن تكون عاملة له الريفلكس symptoms. Surgery, when to do surgery? The best timing for surgery is when the patient wants. failure of medical treatment يعني واحنا طلبة في البكالوريوس لما تتزنق when to do surgery قول failure of medical treatment. ده لا ينطبق على reflux disease. Failure of medical treatment is a poor prognostic factor for success of surgery. So surgery is when the patient needs لأنه مش قادر comply. Fundoplication is the surgery of choice. الباقيين لسه under trial. Stretta did not show good results لكن TIF transoral incisionless fundoplication showed the better ones. And this is backed up by recommendations from the guidelines. So the story is near the end. I saw both of them on regular follow-up, endoscopy for him and clinical for her. He stopped smoking and lost weight, and he was very happy. She stopped coughing at last, and she was also very happy. They were both happily bonding and happy to share everything in life, even the same disease and the same packet of medicine. So they had more to do in common. My take-home message is not about pantoprazole. My take-home message is love your family and enjoy their bond in health before sickness and disease. Thank you very much.